All right, thanks, Mike. He has to run to do a case before the afternoon session in the lab. So if you have a question about TAVR, you can grab him this afternoon. He'll be back. So we can go to the next, to my slides next. There's a lot we could talk about data-wise too, and to Mahesh's advice, I'm really going to try to focus on a more practical talk on minimally invasive aortic valve replacement, and we're breaking this in two parts. Mark Rule will speak after I do and focus on the mini thoracotomy approach, but I'm going to speak to the mini sternotomy. My only disclosure is I do, in this particular space, is I do proctor for LivaNova, who makes the Percival valve, and I will touch briefly on that device. So why minimally invasive AVR? I mean, I think it's pretty obvious probably to those in the room because you're interested, you're here. But a lot of times our colleagues will ask us, and sometimes our more senior colleagues will ask the question, you know, we do pretty well with full sternotomy. We've been doing well. We know how to do the operation quickly, effectively, and reproducibly. You know, what's the point? I always flip it and say, well, why not do it? I mean, is there a surgical specialty across the from head to toe that hasn't moved to less invasive procedures, and for all the obvious reasons? Well, a little bit of history here. In 1996, I'll say, there was the advent of minimally invasive AVR. Dr. Cohn, who really focused on mini sternotomy, deserves a lot of credit for pushing that particular technique. And Dr. Cosgrove at the beginning was experimenting with peristernotomy, dividing ribs along the right side of the sternum, and then also some thoracotomy approaches. To give it context, probably many of you in the room were in maybe elementary school or junior high school when these days, or even earlier. But a company called Hartport and also CTS really exploded onto the scene in the mid-90s with technology to allow us to do minimally invasive CABG and mitral valve, and also minimally invasive or mid-cabs with CTS platforms. And so there clearly was an interest across the board going from a non-sternotomy approach. But I think that the first push by Drs. Cohn and Cosgrove was to really use minimally invasive surgery with conventional instrumentation. There really wasn't a lot of growth in the industry for mini AVR to support new platforms. So the idea was to just do a non-sternotomy approach. And there are some great papers from the day, and it's amazing how many ways we cut the chest open. Lower sternotomy, partial sternotomy, upper partial sternotomy, peristernotomy, transverse sternotomy, V-shaped incisions, T's, L's, J's, and I think we kind of landed on two pretty specific approaches. So after about 10 years of experience, some papers started to emerge, and I think this one, which was probably one of the more controversial papers from John Pepper, looked at, it was a meta-analysis of 4,600 patients who underwent minimally invasive aortic valve replacement, and it was a well-designed and well-done meta-analysis, nothing that controversial, but they really looked at morbidity and mortality. And what they concluded was that there's really a marginal benefit in perioperative mortality, which kind of had a lot of us scratching our head, but there was clearly a reduction in intensive care stay, total hospital stay, ventilation time in the minimally access group, although cross-clamp, cardiopulmonary bypass, and total operation times were longer. Now, suffice it to say, this was the early experience in minimally invasive aortic valve replacement. This is 2008. Patients enrolled in 2006. Really was, the first cases were done 10 years previously. But their conclusion was almost, I don't know, concerning to me. It was a little bit off the cuff even, that they said that it could be offered to patients if they chose to have it, or maybe for cosmetic benefits, but really there wasn't any clinical benefit. I think the conclusions from the data could be drawn differently, but this is what was stated in this paper. The interesting and a really critical element here is this was really a normal risk population. So to show a mortality benefit when you already had an average mortality rate that was around 2%, would be predictably difficult. So the focus really wasn't on some of the morbidity advantages as much as on the mortality. And yes, of course, it was difficult to show. About the same time, Dr. Cohn published his first 1,000 cases. Again, these were mini sternotomies, single center, single surgeon. And what he concluded was, with their results, the minimally access surgery was safe and feasible with excellent outcomes. And he also added a number of patients into this series that had root replacements, ascending aortic surgery, and also reoperations. And a statement was made, although there wasn't much analysis on the elderly, but particularly well tolerated in the elderly population. He followed it up with 250 octogenarians a couple years later and showed that with an STS predicted risk of mortality of 10.5%, that the actual 30-day mortality was 3%, and that long-term outcomes were matching survivals of patients of the same age. And he made a pretty controversial conclusion that these provide a benchmark against which outcomes of transcatheter aortic valve implantation could be compared. So this is about 6 years ago, at a time when the initial results of PARTNER and also CoreValve were coming out, that we had a ODE ratio of 30% in a very high-risk population with minimally invasive aortic valve replacement. And then more recently, Joe Lamelas, now working next door, published a great landmark paper early in his initial experience on his older population. This was a paper combined mitral and aortic surgery, but showed that in his study that there was lower morbidity and mortality when he compared it to a median sternotomy population. Not a randomized trial, but really the first trial that was published that stated a survival advantage. There's just so many interesting papers if you go through it, but again, none of these are randomized. The Leipzig experience with 2,000 patients with mini sternotomy, and a year and a half ago they published in the European Journal a 5-year survival improvement, and these were propensity matched patients. Not a dramatic difference at 5 years, but certainly significant. Look, if you really look through I've got a stack about this high of publications on mini AVR. There's not one randomized control trial comparing minimally invasive surgery to full sternotomy. They're predominantly single institution studies. The minimally invasive patients tended, but not exclusively, to be performed in a bias towards lower risk patients who actually may not have the greatest benefit. I think just theoretically you can imagine that patients who have compromised metabolic status, they're catabolic, they're old, they're frail, were the ones that may tolerate less invasive surgery and the demands of recovery and healing. But over and over, the key advantage were decreased length of hospital stay, ICU stay, blood loss, pain, use of analgesics and narcotics, and recovery time. And now there's some suggestion in this Leipzig paper and now a couple others that there may be a better survival, whether that's selection bias or not, in spite of the propensity matching. Who knows? And cosmesis, which I think in most cases is probably not relevant. My personal experience now, over 600 cases, which were heavily weighted towards high-risk PARTNER 1A control patients and those not ineligible because of high creatinine or aortic surgical needs. I've had in many other centers, not one deep sternal infection or instability with these patients, and a mortality rate at 30 days of less than 1%. The ones that have passed were pretty much earlier on in my PARTNER days with 94. We were having to operate on 94-year-olds and 97-year-olds and people with cirrhosis and very, very frail folks. But still, if you roll them all in, the results are really nothing short of spectacular. I think most of the mortalities that we had early on these days would never even see a surgeon except for as an opinion towards TAVR. Well, just to distill down to all this experience into something I think is much more practical, and I'll spend the rest of the time talking about how to do the mini sternotomy. I think it's pretty clear that these are the two approaches that are most favored. There's clearly advantages and disadvantages to either. Some people have religion on one or the other. I don't. I think they both are not that much difference, and I think the anatomy actually is the thing that really helps you decide which approach is to your advantage and whether or not you need to do something beyond aortic valve replacement. So mini sternotomy, I would say the vast majority of surgeons who prefer this approach make a midline incision and go into the fourth intercostal space. If you've never done one before, it doesn't hurt to go into the fifth intercostal space. All you really want to do is preserve the lower sternum. There are a lot of reasons why this, I think, is a very, very effective and reproducible and safe procedure. But I think the reason that people do so well is, remember, the vectors of force in the chest all aim towards the lower sternum, and you know that from your sternotomy failures and wound healing and mediastinitis. Things tend to happen first at the bottom, and that's because that's where all the forces occur from coughing and respiration, et cetera, and not so much the top. So if you leave the lower part of the sternum intact, I think you've got 90% of the benefit. and you don't really lose much of it in your initial experience to make a bigger incision and even go into the 5th space. But 4 tends to be the easiest way in most patients. 3 sometimes is certainly feasible, and sometimes CT may help you decide. The 3rd space, if you're using the femoral venous access, which I'll talk about in a minute, is fine, because usually what you're really gaining by going a little bit lower is getting more access to the right atrium. In the 3rd space, you have very, very good access to the aorta and aortic valve. So it's pretty simple. This is a 3-inch incision. This is kind of standard. It can be smaller, 6 centimeters. I make an incision just a little bit above the angle of Louis, down to just above the 4th space, and in most patients that gives you what you need. So 6 centimeters on average. Sometimes you can make it a little bit smaller, especially in slender patients. I don't think the skin incision is the issue. As our mentors all said, skin heals from side to side, not end to end, and the real benefit is what you're doing, I think, with the bone. And whether you J it or L it, and sternotomy into the right intercostal space, there's a lot of Eztec-like retractors out there. I have a new one that I like that has lights in it so that the field's always illuminated, even if my headlight's not focused down that way. You open the pericardium over the aorta and the right atrium. Use heavy pericardial sutures to really pull up on the heart and deliver the heart into the field as best possible. I generally will access venous through directly in the right atrium. If a patient is very vertical in their mediastinum, then you may open the chest and not see much of the right atrium. Percutaneous right femoral vein access for drainage is also fine. Also, if you want to do retrograde, you really need to have pretty good exposure to the right atrium, because you need to get your cannula for retrograde in place. And if you're trying to avoid the groin, you can do it, but you need to see the appendage and a pretty good part of the atrium, which oftentimes you do, and 2 purse strings is fine. If not, put the retrograde in through the appendage, and again percutaneously hit the right femoral vein. I use retrograde now sparingly, but in particular I use it in aortic regurgitation patients, using antegrade only in most patients. In terms of the cannulation, there are a lot of options out there. You can use a standard aortic cannula in most patients. I've just gone to using a Seldinger technique with a diffusion cannula, and putting it high just keeps everything out of the way. Generally use antegrade cardiplegic. Custodial is probably not necessary in some of the shorter cases, especially if you're doing a rapid deployment valve, but antegrade cardiplegia in general is all you need unless you have aortic regurgitation. I used to use an LV vent in the right upper pulmonary vein on every patient. I guess I've been more selective. When I'm training fellows, I definitely have used the vent. I think it just gives you a little more safety and flexibility. But certainly in patients with low EF and dilated ventricles, or folks with rhythm disturbances, it's nice to have it there as you're trying to get the heart started again, that you don't have any distension. And then you perform a standard aortic valve replacement. This is a good way to start. I personally feel that moving directly to short shafted instrumentation is very helpful and probably better. And although all of us learned early on using standard surgical instruments, I use shafted instruments even in full sternotomy AVRs now. And I think you just have better ergonomics and better. It's just easier to put the sutures in, basically. Core knot, yes. There was a lot of excitement about how this makes the operation faster. I think it does make it a little bit faster, but that's really not its benefit. By not sticking your fat finger down, or your slender finger in some cases in the room, and potentially tearing the aorta in a small root, or I think this core knot offers that benefit. And also you really get equal tensioning all the way around the aorta versus 6 knots, 6 knots, 6 knots, 6 knots, where you probably are not consistently tensioning. And I think part of the problem is when we have the occasional PVL is that you really haven't been able to seat the knot in the valve properly. I also put 3 tourniquets at the naders of each valve. I started doing that with my trainees, but I think it really does help in a very small incision to make sure the valve is seated completely, and then put the core knots, and then take the tourniquets off and put the core knot on last. I believe core knot, I have no financial or any other interest in this company, but I really do think it's been revolutionary, and certainly was helpful in mitral. And now even in aortic and in limited access patients, it really makes the operation, it streamlines the operation, and I think it makes it safer as well. Moving on with the technique, you're through a small hole, don't know how quickly the heart's going to start. It's important to put a pacing lead on before you take the clamp off. And sometimes in very cramped mediastinums, the clamp comes off and you never see the right ventricle again. It's very difficult even on pump. So I use bipolar lead on the RV. They have some, Medtronic makes a very nice small one, the small needle, so if you don't want to stick the larger one in, which we use on the open cases, there's some nice low-profile needles, very easy to use, and just bring it out through the bottom of the incision. Also, make sure you put the chest tubes in before you come off bypass. I like to come subxiphoid up through the middle with a Blake or a chest tube, doesn't really matter much. I know that Ross here, Rule, taught me a technique. He takes the venous cannula out at a port on the side of the chest for the right atrial drainage, and then uses that for a chest tube through right chest. I try to stay out of the right chest if possible, and sometimes you get into the pleural, sometimes you don't. But it's nice if you can do it, avoid the pleural space, from my perspective. But it's also a very nice technique. De-airing has been a criticism of minimally invasive aortic valve replacement. Because you can't just get down there and wiggle the heart with your hand and bring it up and down and stick a needle in the apex. But it does take sometimes a little bit longer to de-air, whether or not flooding the field with inert gases or CO2 is helpful. I haven't found it helpful in the mini AVRs. I don't think it's difficult to get the gas into the ventricle and into the atrium. But suffice to say, I think it's possible. You just have to be guided by TE before you separate from cardiopulmonary bypass. I'm a big believer in plating. Used all the different systems, and I think I started being convinced back in the early part of partner days with all these old osteoporotic sternums and manubriums where the wires pull through. It's a very nice way to stabilize the sternum reliably, consistently, especially in bad sternums and tough patients. It's also very beneficial, I think, in very obese and diabetic patients. And so I do use it routinely in the mini sternotomies. So here's the view. You can pretty much see all you need to see here. It's just all the cannulas in this case are here just to show you everything can be done. There's a retrograde, there's a venous cannula, an aortic, and an antegrade root vent as well. And once the valve is, when this aorta is cross-clamped, the valve's sitting right in front of you in most cases. If it's not, it's probably because you didn't tension the pericardial sutures well or place them well, but generally it delivers right into the field, and you can excise the valve and sew in with short-shafted instruments and coronat and close. I again mentioned that I have done these initially more in the frail patients. This is a lady who has a low incision as a mini sternotomy, and 1 week after surgery and 2 weeks before her liver transplant, it was recovering well and went on to have a successful liver transplant. Very frail, very catabolic, never had a problem with her chest wound, and we were 7 or 8 inches above the chevron incision she got for the maximally invasive approach to her liver transplant. But does well, and I think over the years it's pretty clear to me that the patients who benefit greatest usually are these more frail and metabolically challenged patients. There's been a lot of reports, I've done all these myself, of concomitant procedures, aortic valve replacement and repair clearly, but root enlargements, valve sparing roots, extensive root and aortic endarterectomies, a lot of these folks early on, I think they're all getting pretty much tabbied unless they've got an aortic aneurysm. Bentals, aneurysmorrhaphy, and hemiarch. Eric Rosselli was the first one to challenge me years ago, wondering why I didn't do hemiarches through this incision. It's very easy to modify the technique and do the arch work as well through this incision. The arch is sitting right in front of you. You don't need the lower sternum to access it. What about redos? Larry Cohn was the first one to really promote this. It's interesting that he didn't have, when he had his redo aortic valve replacement, he did not have a mini sternotomy. I think that's because he couldn't do his own operation. That's my thought, but one of the Cleveland Clinic representatives may have a different comment on that. But it isn't as bad as it sounds. It does take a little bit of rejiggering in the way you kind of approach the patient. Preoperative CT is essential. You got to know where the grafts are, if there are previous grafts. Most of the time when we say redos, it's not a redo aortic valve, it's a redo in a patient with prior grafts. An oscillating saw is fine. I just go down the same incision and then just take the saw and put the small blade on and get out into the right fourth intercostal space. It's not essential to cannulate the axillary artery. If you see on CT, you're very free behind the sternum. There's plenty of room. Generally speaking, you can still go through the ascending aorta, but clearly the venous drainage is much easier from the groin. So just like we do in TAVRs, and almost every patient that gets to my clinic, I'm sure those of you involved with this are getting a CT. Either they've already had it or you're going to order it anyway to see if they're a candidate for TAVR. But it's very helpful. to determine the best way to access the patient. I look at the angle of the aorta. Many of us use 45 degrees up or sideways to determine if you're going sternotomy or thoracotomy. It helps you understand where the grafts are, where the aortic calcification. And because you can't get your hand and to touch everything, it really lets you understand the rest of the mediastinum well, I think, and anticipate some anatomical challenges. And obviously, if it's a redo, understanding where the grafts are from the previous operation. Next question is, can we make this procedure better and faster, safer, shorten the ischemic times? The criticism early on was that these operations take longer. Clearly, with experience, there are a number of studies showing that we have very similar cross-clamp times and pump times of minimally invasive. Can we put a better valve in and still remove the pathologic valve? So the hemodynamics of TAVR are outstanding, but some of the new valves available may offer us an even better hemodynamic result. We know ischemia is bad. That's not news, but this is a great paper from Ranucci in Milano just a few years ago, where they looked at a very large number of patients who had isolated AVR, and he looked at aortic cross-clamp time as an independent predictor of cardiovascular morbidity, and he found that an increase of 1.4% per minute was the consequence. So maybe this is our door to balloon time equivalent, but the patients with left ventricular ejection fraction less than 40 or diabetics showed the most benefit by reduction of cross-clamp time. And so an additional challenge, I think, to us although, okay, I can do it in 40 minutes or 50 minutes or 60 minutes or 25 minutes, but just to know kind of collectively, the more we can expeditiously move through the ischemic period, there is some data that, yes, it does make a difference even if you're under an hour. And this is a great paper. It's been very difficult to criticize it. Been on many panels looking at it, but I think this is a real phenomenon, and we should not hang our hat on an old adage that if you're under an hour, you're fine. I think there are some advantages. And clearly, there are two products out there that potentially can help us with that. Two very different. On the left is Percival, which is a self-expanding nitinol valve. Lends itself very well in small roots, especially because it's sometimes those are the most challenging patients. And then you don't want to do an aortic root replacement if you don't have to on the older folks. May have very calcified aortas. And on the right side, the intuitive valve from Edwards, which is basically a magna valve that sits on top of a stainless steel covered stent. They are both, quote, rapid deployment, and I think they're both, one is sutureless and one has only 3 sutures right now, but they do offer potential advantage in these minimally invasive patients. There's a lot less trying to get all the sutures around. If you become comfortable with one or both of these, I think it does offer an advantage in terms of time. And my experience has been greater with Percival, and the hemodynamics, even in the small valves that you put in, you can barely put your little finger in there, really a single-digit mean gradients is really gratifying without having to do the root enlargement. So Italians never get out of the room without quoting one of our ancestors, but whoever desires constant success must change his contact with the times, Machiavelli said 5.5 centuries ago, and I think that is relevant to this conversation and also this meeting. So I'd like to conclude by saying minimally invasive AVR appears to be beneficial. It's clearly desirable in many patients, and I think it's pretty clearly been determined to be safe. I think it's really particularly beneficial in the elevated risk patients. We focus on the lower risk patients, minimally invasive cosmesis, but I think we need to flip the coin here. There's a lot of data and a lot of experience that would indicate that the patients that may benefit greater are elderly, more frail, people that aren't TAVR candidates, and something to be considered. You can use standard instrumentation and cannula, but I think facilitating technology is helpful. I can upstairs this afternoon. We'll have some of the equipment up there. We can kind of talk about details. Some of the stuff's not very expensive. Some of it is. Advanced imaging is essential in determining the best approach, especially in the reops, as well as identifying confounding conditions. There may be further benefits from sutureless or rapid deployment valves, and concomitant procedures on the aorta are certainly feasible. So I thank you for your attention.